Hello and welcome to the HRC egg freezing seminar that we will be doing this lovely Thursday afternoon. My name is Dr. Alison Peck and I'm one of the physicians at HRC Fertility in Encino, and it is my honor to be able to present this topic to you all today. If you have any questions through the course of this lecture, you could hit on the question tab. Most likely I will choose to answer all the questions at the end of the session, so we'll make sure to end this a bit early to make time for all of your questions. So before I start, a little bit about me. I've been working at HRC since 2000 for the past 7 years, and before that I did my OBGYN training at LA County USC in Los Angeles, and I did my reproductive endocrinology and infertility fellowship training at Albert Einstein College of Medicine in New York. And in 2006, I came back to my hometown, which is the San Fernando Valley, and I've been practicing in this community ever since. So I love this topic. I named this topic, Egg Freezing, Should I Do It? Most of my patients that are considering egg freezing have a lot of questions. Many of the patients that come in are not even sure for sure that they want to do it at all. So the point of this conversation and this discussion is for you to explore what it is to do egg freezing and to decide if it's right for you. And if you come to that decision, I would be more than happy to help you on your journey through egg freezing. So without further ado, we will get started. All right, so the good news, egg freezing is no longer considered an experimental procedure. So for many years in the beginning of my training, it actually was. And more than 5+ years ago, that title was lifted. And the reason for that is because more than enough data has been produced on successful cycles of women that have frozen their eggs, thawed them, and used them to achieve healthy babies and healthy pregnancies. And therefore, our society, the American Society of Reproductive Medicine, that used to oversee all practicing REI physicians, of which I am, lifted that title. And since then, it's been much more widely spread. All right, so what are we going to be doing within the next hour? My goal is to educate, as I said before. So by the end of this talk, I hope each of you will know what is egg freezing, who can benefit from egg freezing, what the actual process of egg freezing is, and what are the clinical outcomes and some of the risks that may be associated with the procedure. Of all the things I'm going to say, I think the one that's most instrumental and helpful for the majority of women that are considering doing this process would be what is the actual process. And that's because this will help you figure out if this is something, let's say you really want to do it, how you're going to fit that into your life, and if scheduling wise, this is something that you would really be able to do. All right, so what is egg freezing? So the technical terminology is oocyte cryopreservation, and that's because oocyte is the name for a human egg, and cryopreservation is the process of freezing human tissue. And the technical definition is the cooling of eggs to sub-zero temperatures in order to stop all biological activity and preserve the tissue for future use. Now, tissue preservation has been going on for centuries. It was just that egg freezing was not, the methodology of egg freezing was not as advanced as it is today. So some of you may be asking, what type of egg freezing technique do we use in our laboratory? And that's a very good question. So we use a process called vitrification, which is a fast freezing technique. And for many years before that, we had another technique called slow freezing. And what would happen during slow freezing is the egg, which the majority of the egg is made up of water, when we would freeze the egg and then thaw it, the parts that were water would form little ice crystals. And so in the thawing process, those crystals would lyse, and then in the end, the egg would basically not survive the thaw. But ever since the process of vitrification came about, our egg freeze and thaw rates have been well over 90%, and we have not had this issue, and therefore the success rate of the process working has increased. And that is also closely in conjunction around the time when that experimental nature of the procedure was lifted. So here at HRC, we use the vitrification process to freeze and thaw eggs. All right, so let's go through a little bit of history just to orient us. The first IVF baby, before we get to that, let's go through different freezing procedures that have been done for fertility in history. Number one, in 1953, the first human birth from frozen sperm was achieved. This is a picture of frozen sperm. And now we're going to move into an embryo, which is the combination of the egg and sperm together. In 1984, the first human birth was achieved from a frozen embryo. And now, in 1986, the first human birth from a frozen egg. So, as you know, this is not a new procedure. It's just become more of a commonality, more talked about. Much more women feel more comfortable with it, and the success rates have gone so much higher that therefore this procedure may seem kind of new, but it's actually been around for quite a while. All right, so let's move into who are the people that are thinking of freezing their eggs. So many years past, the whole purpose and beginning of why egg freezing came about is for women that were unfortunately undergoing cancer treatment. And before they went through that treatment, knowing that either the chemotherapy or the radiation treatment would have a potential negative impact on their eggs, we needed to have a procedure that would help these women preserve their fertility. So that was the original interest in why egg freezing came about. But ever since that happened, there have been quite a lot of other implications for why women would maybe want to freeze their eggs. Number two, a history of known genetic conditions. So there are some conditions that the women will find out genetically that maybe at some point in time their egg supply is going to go down, and they wanted to prevent that. And I won't name them, but there are also some other conditions, such as conditions that are linked to breast or ovarian cancers, and women are doing prophylactic surgery to prevent them developing ovarian or breast cancer. And in the process, clearly they're no longer going to have their ovaries, and then they're not going to have their eggs. So this would be another group of women that would be interested in freezing their eggs. And again, there are definitely some procedures within our lab and our patients that are currently going through fertility treatment, which always encompasses a woman taking eggs out and our lab mixing those eggs with sperm, creating embryos. And there have been instances on the day of the egg retrieval when we're thinking that we're taking those eggs out, for whatever reason, unfortunately, there is no sperm available. Therefore, we need a procedure in order for us to freeze those eggs for future use. And once we're able to get sperm available, then of course we will be mixing the egg and sperm together. And then, big topic, donor egg banking. In many, many instances, there are women that are going to need to use eggs from another person or donor eggs. And for years, there have been sperm banks to allow men to use sperm from men that have been previously frozen in our banks, in banks in the community. However, there was no availability for frozen donor eggs. And again, that was because the success rates were so low. But now there are quite a variety of egg donor banks, and this has been a great benefit because we can use those eggs instead of having to use fresh eggs, which is kind of a conversation, but still worth addressing. That we can use the donor eggs that are already there and available for women to use, and it's more practical and sometimes more convenient or easy for them to access those eggs if needed. And then there's the big topic which so many women are coming to do egg freezing for, and that is the delaying of childbearing. So in this world today, women are blessed with so many opportunities, whether it be educational opportunities, work opportunities, and they are choosing that through their 20s and 30s, which is an ideal time to be having children and getting pregnant, they're actually choosing other roads. And in that time, there's an anxiety that's produced appropriately, because we all know that as women get older, then they lose their egg supply. And in order to stop them from losing their egg supply, the goal is to try and save some eggs so that one day in the future, when they are ready, they can come back and use those eggs. And it would be as if they had tried to achieve a pregnancy at the age that they actually gave their eggs. For example, if you're around 34 years old and you choose to freeze your eggs, and then somehow 40 comes around, you're like, you know what, you try and get pregnant, or you just say, you know, I'd rather use eggs from when I was 34, then the eggs that we would use would be 34-year-old eggs, no matter what age it is that you are when you're ready to use them to get pregnant. So that's pretty much a very big audience of who we see today. And although I write here that the ideal age to do this is less than 38 years old, we do have patients that are over 38, by all means, that are coming to freeze their eggs. This is a very selective decision. This is a doctor-patient decision, or what is the appropriate age and how old should I be if I want to freeze my eggs. The reason I chose 38 is because as we get older, women's eggs, not only do the number go down, but so does their quality and the health of the eggs. And in many cases, we're not going to know the health of your eggs or their quality until one day in the future when we mix them with sperm, and then we could test to see if the eggs were healthy. And women that are less than 38 have a higher percentage of having healthy eggs. And so in that time delay between knowing if your eggs were healthy and you choosing to have a baby, the younger we are, we encourage those women to freeze their eggs. All right, we're going to move on. Okay. What are we going to do in order to figure out how we're going to set up your cycle and get you ready to freeze eggs? And number one, if it seems like you're an appropriate candidate. So every time you come to see us, and even before, you're more than welcome, please, to fill out your health history before you get here. But if not, once we sit together and we get to know each other, we're going to be going through your gynecologic health and your general health, just to make sure there's nothing about your health that may negatively impact your cycle, or if there is, something that we can address to get you well prepared, such as what medications you may be taking, some certain lifestyle habits like your use of tobacco or alcohol, your exercise patterns, certain things, what kind of a diet that you have. In any case, the next thing that we do after that conversation is we're going to do some sort of a physical exam, and usually that entails a pelvic ultrasound. And these ultrasounds are done vaginally because that is the best way to access and look at your ovaries and see how active they are. So one really important test is called ovarian reserve testing, and there are specific times in the month where this is best performed. Definitely on a menstrual period, within the first, second, third, fourth, or even fifth day of the cycle, it's important to have a pelvic ultrasound to take a look at your ovaries to get an idea of how many follicles there are. So we call this your antral follicle count. And we use that number to help decide what type of medication you should be taking through your cycle and what type of expectations that we may expect for you and about how many eggs we think we're going to get. So that's called your antral follicle count, again, best done around your menses. And then we do some other hormones. One's called your AMH, which can be done on any day of your menstrual cycle. For example, if you happen to come to have a consultation and you are not on your period, no problem. We'll get an AMH value, and when your period comes, we'll plan to see you on your period to do that ultrasound, and then get the final tests, which are the FSH and the estradiol, to really access how fertile you are. Again, this is all called ovarian reserve testing. Once we know that, it's pretty easy to map out and plan your cycle. The only other thing by California law that we're going to need in order for us to freeze your eggs is a sexually transmitted disease panel, things like HIV and hepatitis, chlamydia and gonorrhea, and so we have a list for this. And the reason for that is because we are going to be freezing and housing your eggs in tanks in our laboratory indefinitely for as long as you want them to stay here, and everybody else whose tissue has been in that tank or goes in that tank will also be screened for any infectious diseases. So these are simple blood tests. Okay, we're moving on. This is that slide I foreshadowed. I think this is the most important one to perk up and pay attention to. So what is the process of egg freezing? keep in mind that there are many, many places and many different doctors that have different types of protocols. This is the most common protocol. It is possible that if you go through egg freezing, you will not follow this exact regimen, but for the most part and for purposes of planning, I'm going to speak about this one. So the cycle pretty much runs over about a 2-month stretch of time in your life, starting with a menstrual period. So this part over here is going to be the first month, and that oftentimes won't even last a month. But let's pretend like you just got your period and you're thinking, yep, I want to get started. You come in on that period and you have that pelvic ultrasound I just mentioned, and then you start the birth control pill for anywhere from 2 to 3 weeks. And during that time, you're really not in any treatment. It is smart to be your healthiest version of you. This is where your history and the things I mentioned before, like your recreational habits, this is a time where we really want you to be cutting back on that. If we're going to have you on prenatal vitamins, this is a great time to do that. But for the most part, this is a rest period before we actually start the stimulation to help you grow your eggs. So again, about 2 to 3 weeks on birth control pills. And during this time, you'll also be given a calendar by our nursing staff that will tell you and highlight what to expect for the upcoming month so that you can have plans and you can, before everything gets started, you can pretty much know the expectation, how often we're going to need to see you in our office. So now we're back at the end of the birth control period. You come back for an ultrasound over here. Most women will get a little period, menses, right after finishing their birth control pill pack. And at this appointment is where you're going to learn how to use all the medications. So quick point to pay attention to, beyond the multiple appointments that we're going to need you for, which is an average of 6 throughout the process from start to finish, you also are going to need to be taking medications self-administered that are injections. These are tiny little needles. They're needles that diabetics use. They're like the insulin needle, very small needles that go under the skin in the abdomen. And you're going to be taking these on a daily basis, anywhere from 2 to 3 shots a day, self-administered for an average of 10 days. So at this appointment, you'll have an in-the-office consultation and review on how to take those medications. We do have patients that have a really hard time with the shots. There are always ways to coordinate with nursing staff to try and help patients get through these shots. But for the most part, after doing it a couple of days, most of our patients will be doing these by themselves or having a friend do them for them. So now you're in your stimulation. So every day for those 10 days, you're taking these shots and you're going to come to our office periodically, anywhere from 3 to 4 visits. And each of those visits, we're basically watching your ovaries change and we're watching how your eggs are growing. And the eggs grow in something called follicles. And these follicles have a goal size. And usually once they reach that goal size, which is on average around the 10th day of drugs, they will be ripe or ready. The eggs will be ripe or ready to come out. So just to explain one step further, ideally each follicle that's growing nicely will have an egg. It doesn't always happen that way, but we will have an idea as you're going through your stimulation how many potential eggs you may be making. And the reason for the multiple appointments is because we want to make sure that you're going at the right pace, that whatever your ovarian reserve is and whatever our expectation is of how many eggs we think you're going to be able to have out, that they are growing nice and uniformly in conjunction with each other, and that your hormone levels that you're getting done on each of those appointments are reflecting how many mature eggs are growing. And that is the reason. So if there's any moment in time through that stimulation that we feel we need to fine tune or change your dose, those are opportunities for us to do that. Now, once we get to this day, again, usually around day 10 or so, and I'd say about 95% of people take 10 days. There definitely are people that will only take 9, and then there's some that'll take a couple more. And so we do need your calendar to be a little bit flexible with your life and work and school schedule. But for the most part, once we get to that day, we're going to tell you, okay, you're ready. We're going to be taking your eggs out within the next 2 days. So you will have a heads up warning 2 days before your procedure, the actual time of the procedure. And this is the big moment. This is what you've been waiting for. At HRC, I'm very blessed because everything's all under one roof. And so that means that after you've been coming for these appointments, and let me also add that if you are an outside patient, for example, maybe you don't live nearby, or maybe you live close to one of our other HRC locations, by all means, those other appointments for convenience as you're monitored could be done at other places as long as we get the same day results. But most of the time, at the very least, we absolutely want you here for that final ultrasound appointment to plan the final preparation for the retrieval. So all our retrievals are done on site in our Encino office. You will be with us that day for about 2.5 hours. We'll need you to have somebody here to take you home. The procedure itself only lasts about 20 minutes, of which you are under anesthesia. So please remember that you will not be feeling anything that happened during this procedure. You will be out completely. You're here for about 2.5 hours. The first hour, you're just checking in. The procedure, again, takes the 20 minutes. And then after that, you rest for about 45 minutes. And then you're discharged and you're asked to go home and rest it out till the next day. And most of our patients really do fine in terms of pain management. We do give you pain management, but by the following day. During the procedure, I think I'll move on because we have a nice slide on this, but I'm going to start talking about, we're going to move into a visual of what I just said, and then you'll see how we do the procedure. So number one, here's an example of a woman who's injecting herself location-wise with the hormones for that 10 to 12 days. Then we have step 2, the removing of the eggs. So while you're sleeping, a pelvic ultrasound wand will be placed in the vagina, and with a small needle poke through the vaginal wall and directly into the ovary, we will be taking out the eggs. So although this is a surgery, there will be no scars or future way of knowing that you even had a procedure done, because everything will be done vaginally. So this needle will poke once to this ovary, once to the other ovary, until all the eggs are drained from that month's cycle, and then the procedure is over. And now we have your eggs, which look like this, in our lab. And it's important to note, although a small little detail, that this egg is what we call a mature egg. So some women will make a nice group of eggs, but they won't all come out mature. So just like a really nice juicy apple or a ripe piece of fruit off a tree, sometimes you'll have a really ripe, mature apple, and sometimes the apple next to it may be a little less ripe. That's an analogy for maybe mature versus immature eggs. So the goal is to get a nice cohort or group of mature eggs in a batch. And so if it has this appearance with this little polar body over there, then this is the sign of a mature egg. More to be discussed on that through a consultation. And basically, that is the end of the cycle. All right. So one day in the future, if you would come back and you want to use these eggs to help you create a baby, then a couple steps are going to have to happen. And although most women at this point are like, I'm done, wipe your brow, I did my cycle, that was great. You should really know for the future, well, what are we really going to do with these eggs, and why, and what is our end goal? And obviously the end goal is to get a healthy embryo, which will ultimately lead to a healthy baby. So I'm going to try to highlight for you the future forecast of what would happen when you're ready to use your eggs, and why it's important to think before this gets started about how many times you would want to go through an egg-free cycle. So I just gave you an example of one actual full egg-free cycle from start to finish. It's not unusual that our patients will choose to do more than one, and with guidance from us or one of the physicians, we'll be able to tell you what would be maybe the best number for you. On average, I would say most women do somewhere between 1 to 3 cycles. The younger the woman, the more we get, they do fewer. The older the woman, often we do more. Because remember, it's not just the number, but it's also the quality. So now we have your eggs and we're looking to the future. And one day we're going to take these eggs and we're going to mix them one by one with sperm. So this picture over here is a process in which we take the egg, the lab will pick up a healthy sperm, or hopefully a healthy sperm, but one sperm at a time, and with a little needle, we'll inject the sperm directly into the egg in a process called ICSI. And this is trying to maximize the rate that your egg's gonna fertilize. Not all of your eggs will necessarily thaw and survive, and not all of your eggs will necessarily fertilize. So again, if you get, let's say, 10 eggs, most likely you will not end up with what's over here, an embryo, 10 embryos. There is pretty much always a fallout between the number of eggs a woman gets and the number of embryos that yields. And then once we get to the embryo stage, we have these wonderful tests today that can allow us to tell you beforehand, before even using the embryo, if the embryo is healthy. And I say healthy like that because this will not be checking every potential illness and disease that embryos or people can have, but there is a large amount of testing that actually could be done on these small embryos to make sure that these have the best chance of going into the body, implanting, surviving, and making a healthy baby. So moving on. Let's go back to what I was referencing quite a few times in this talk before about the importance of doing this at the youngest version of you when you are ready to freeze your eggs, because as we know, like I said, and here's a graphical way of looking at it, that the percent of normal eggs definitely goes down as we age. So for example, over here, these are women less than 30, maybe about 50% or so of the eggs are okay. Once we get to around 44, 45, only about 2% of eggs are normal. And that is the reason why it is harder to get pregnant as we get older. Please don't take out of context the fact that I'm talking about egg freezing and your chance of having a baby. They are two totally different ideas, important to bring up with a physician during a meeting. Even when we do your ovarian reserve testing, this causes often a lot of anxiety for some patients if their levels don't look so great. But remember, we are using these levels in the context of helping plan a good cycle for you with good expectations and good drug regimens so that we can make the most of the egg supply you do have, not change the egg supply you have, because wherever you are in your life, that is your egg supply. Women are born with a certain amount of eggs in their life, and as they get older, they just lose and lose and lose their eggs. So the goal is to capture a month of your life in which if you didn't save your eggs, they would have been gone. So the reason why I show you this graph like that is because I visually want you to understand that at the end of all this, we are really doing the procedure of IVF, which I just spoke about, in vitro fertilization. And in order for you to understand success rates of, well, how successful is it going to be if I freeze and thaw my eggs and try and make embryos, you really have to see this graph. Because basically the success rates of IVF and having babies in this way serially go down with time in relation to the age of the woman in the exact same way that we see the percent of normal eggs go down. Okay, so, and here you go. Here's a slide on that. And all I really want you to do and understand in this slide is that same trend. Every IVF or fertility clinic reports their numbers of how successful their IVF cases are per year in women in different age categories. And I'm proud to say that HRC is always above the national average. And this particular year in life that these were our statistics, this year our 35 to 37-year-olds were very, very successful. And that's why you see a skewed area over here that about almost 70% of our patients in that category were successfully pregnant. But I really want you to just look at that same downward slope. And again, that is the impetus for encouraging women to do this as soon as possible. Good question that somebody may be asking themselves in this moment, and that would be, oh, so let's just say, and I referenced this earlier, I'm 35 when I freeze my eggs, but I actually came back when I'm 40 to go use them. So your IVF or your potential success rate, remember, would be the success rate that you would have had when you were in your 30s, not the success rate of how old you are when you're 40. Okay, so here is a very busy slide which talks about some of the randomized controlled trials of patients throughout the world that have gone through whether it was fresh egg and IVF or frozen eggs and IVF. And they tried to put this summary slide together. I did at some point in time for people to see, well, how am I going to compare what to expect in the future since I really may not be using my eggs for a long time. So what I want you to see on this slide is basically only 2 or 3 things, because wherever you go to freeze your eggs, you really need to have confidence in the lab. The lab is going to be doing the majority of the work. So the doctor's, of course, important. We're the ones getting out those eggs. But once we get those eggs out, we need to make sure they're in a good home, and that when we want to use them, that we will have a good success rate with them. So the first thing you're going to want to ask is, what is the expected general survival rate after you freeze and thaw an egg? And if you were paying attention in an earlier part of this talk, we talked about vitrification process, and I told you that that's the first step, that once we thaw the egg, it has to survive. So we really like the survival rate, if you look at this line, to be somewhere above 90%. That's considered pretty standard. So again, if you had 10 eggs, maybe one of them isn't going to survive the thaw. Next, fertilization. Was there any difference in these 4 different studies that showed the fertilization rates between embryos that were frozen and embryos that were fresh? V is going to stand for the frozen. And for the most part, the fertilization rate was above 70%, and it was pretty equal between the two. So next question for you should be like, what's my expectation that after you thaw my eggs and whoever survives is which eggs, what's going to be my fertilization rate? Again, the goal is about 70%. And then from there, another one to kind of put your eyes on, but can be a little confusing to explain, is what is the general success rate per egg that came out that was thawed, fertilized, and then transferred, the likelihood that that egg would have gotten me pregnant. Now with that slow freeze process that I talked about before, the rates were really no better than 4%. And although it looks a little like meager in this category over here, you can see that per egg, this is not overall per your whole cycle, because ideally women are making on average about 10 eggs in a cycle, and that is individualized and again addressed per patient, but for the most part within 10. This is per egg success rate. This is not overall success rate, but this new methodology with the vitrification has increased this number to up to about 12%. Which is great. Okay, here was the reason I showed those overall global statistics, is because we have statistics too. Now, please keep in mind that these were the very, very beginning of some of the time when we really started to do quite a lot of egg freeze cycles back in 2014 and before. So there is definitely some more updated information that is not on this slide. But for the most part, the reason that I put it here is because I want anyone and any patient coming to our practice to understand that we feel very proud of our rates that are, and which is probably the most important thing to do when you choose a fertility clinic, that's something that egg freezing is a part of their daily routine, that the lab is competent in doing the procedure, and that our rates are definitely up to the standard of care. And in all categories here, which is survival over 90%, fertilization over 70%, here about 80%. And in this cohort of patients, about 70% of our patients got pregnant using whether it was donor frozen eggs or their own frozen eggs. So we feel I feel very good about offering this procedure to patients, and I have quite a large part of my practice today is actually egg freezing. All right, so now we're going to go through a little bit about the future, and another great question for you to ask yourself is, well, is there any difference with my potential baby if I had had my baby naturally, if I had done baby through IVF at the time I chose to take my eggs out and I didn't freeze them, versus my eggs that had been previously frozen and then made an embryo to make a baby? And for the most part, although these children are young and most of them are just in their first decade of life, there's probably just maybe thousands throughout the world of babies that have been born from frozen eggs at this point in history. But for the most part, these babies are being tracked, and at least these 2 studies have shown that at least over 900 live births have happened, that have occurred from frozen eggs, suggested no increased risk of congenital anomalies compared to the general population. Not even to an IVF baby, but just the general population. And in the general population, about 2 to 4% of babies are going to have something wrong when they are born. And that rate was similar. As well as another study showing about another 200 infants born from 165 frozen eggs also show no difference in birth weight or congenital anomalies. These are anything big or small on the baby that we wouldn't expect to be there, compared to those that were born. So these were frozen eggs compared to those born after women had used fresh eggs and IVF. So that is all very promising information, and it also encouraging to make this a real process. All right, some of the risks. I would say for the most part, most of the risks will gather around how a woman feels on the medication she's taking, and then of course the response to the medication. So starting with feeling. So most women don't feel too many side effects in the very beginning, although being tired or having some headaches is not an uncommon thing people may say for the first 5 days or so of treatment. The most common feeling is pressure or bloating or a fullness in the pelvis. And each of those appointments that you're coming to, we're basically looking for that. We're monitoring your symptoms, and we're also looking for how you're responding. So if you're not responding very well, that's kind of a risk. Usually we know which of our patients who have the lower reserve that we're not going to get that many eggs out of off of a cycle. Those are the patients that maybe would have a poorer response. And honestly, to combat that, many times those patients cycle more than one time. But from a symptom standpoint, they really don't feel that much different. And then there's the opposite of that, and those are the women that are making well over like 20 eggs at a time. And those patients are at risk for something called OHSS, or ovarian hyperstimulation syndrome. And that is the reason why we are seeing you so frequently, to try and do what we can to avoid a woman from getting this. This is a syndrome that actually happens the week after the retrieval is done. And luckily today there are certain medications that we can manipulate and modify during your treatment cycle that can try to avoid this altogether. But if so, it does happen. The woman feels bloating and pressure, has a little bit of temporary weight gain for about a week after the procedure. That is a self-limiting process and is pretty much gone by the time the period comes, about 2 weeks after the procedure. So that is something that we're definitely looking out for in our patients that are using fertility drugs to make extra eggs than they otherwise would have in a month. The other is that you're going to be having a surgery. So I did talk about the surgery a bit, but remember the surgery is done vaginally. It is still considered surgery because it is an invasive procedure. And most surgeries, no matter what kind, big or small, have 4 potential risks. All of these usually being about less than 1% of time these things happen. But that would be things like bleeding or infection or anesthesia risks, or the needle touching something it should not be touching, which is only your ovary. And so all of our procedures are done under ultrasound guidance, so we know exactly where we're going. So we feel like overall this is a really safe procedure. Then there's something called ovarian torsion. Also, luckily, not seen often, but each of us have had our case of ovarian torsion. And this is when the ovary, as it's gotten bigger and bigger and swollen up with all these eggs, moves and flips. So that's an ovarian torsion, and that is actually a medical emergency. So in many cases, a doctor or I will say, oh, it would be best if you don't work out during your cycle. Nobody, especially people that work out, nobody really likes to hear that. But the reason for that is because we want your ovaries to stay stable and in a quiet place throughout your cycle from start to finish, so we don't have to worry about this ovarian torsion. Now, next, guarantees. Of course, even with IVF, there's no guarantees in life. There's also no guarantee that your egg is necessarily going to end up as a baby. You see how the eggs to embryo, maybe I spoke before that there may be a fallout. We don't ever know for sure until we actually mix them if you're making healthy embryos. But this is the process, and that is basically what the risk is. This is an insurance policy for you in the future that hopefully, just in case, if you get to an age where you no longer have eggs or you don't have healthy eggs, that you could come back in time and use your healthier, younger version of you eggs with the hope that this will eventually be a baby. And then, as I just mentioned, that there's some data on how these children are in the early decades of life, but clearly long-term data needs to be collected to see the overall outcome. Okay, as we're coming to a soon close, I will open up time for questions in just a moment. But in general, we spoke today about how egg freezing, its success, and the preliminary safety data are all very reassuring and encouraging, and by all means why we are telling our patients that we stand by this treatment, we believe in this treatment, and we feel like it can give you an excellent option for preservation of your fertility, that this is not an experimental procedure anymore, and that is because we've found that the pregnancy rates with frozen versus fresh eggs are relatively equitable. And of course, we spoke multiple times about how our youngest patients clearly have the highest levels of success. So if you are thinking about this and you're one of those, should I do it? Should I not? If you are ever going to do it, you need to just go ahead and do it. Because your eggs aren't getting any younger. They've been with you your whole life. And if they want to be saved, they want to be saved now. And the final point in just being that there are definitely patients that have frozen their eggs and they're hoping that just in case this is where they're going to come back and they're going to use these eggs. But by no means at any point should this mean that if you are thinking of trying to have a baby that you shouldn't just go ahead and try. This is a backup plan for the majority of patients, but for some patients this is also the first plan. They want to have a baby from their eggs when they were younger. But again, it doesn't mean that when you finally get it in your head that you're ready to have that baby, that you shouldn't at least give it a try. Okay, so the final thing I just want to point out is I was very, very fortunate and blessed to be a part of this new wonderful book by Brittany Hawkins and Catherine Hendy. It's called Everything Egg Freezing, and I have my own personalized signed copy here. And this is a book for patients that, so much is covered in the doctor's office, all these very technical terms that I said, and the formality and the seriousness of it all. But these two women are actually survivors of an egg freezing, and they live in different parts of the world, and they came together and wrote this book for anybody considering egg freezing. And it's like having a backup buddy throughout the entire process, whether you do it through a book, which goes through what to think about before the process, a lot of things that came up, and even more with humor and excitement. And it really just brings in the camaraderie of it all, like women standing up and being there for other women. And they've made a wonderful pilot study too right now that's going on for any woman that's thinking of freezing their eggs. So if you do feel lost or alone, I mean, at least I hope my patients don't, but if for whatever reason you need a little bit more support, even just to make the decision, or while you're going through it, should I do this, should I do that, and just to have another listening ear there for you, this is a wonderful opportunity that I tell all my patients to reach out to connect with them, so you feel like you are on a journey, not all by yourself. So without further ado, I will open up the time to any potential questions. Thank you all so much for joining me today and spending your lunch break with me and learning about egg freezing. And I hope I have the opportunity to meet with you and take care of you. So let's go. Oh, this is a wonderful question. Do you have stats on how many thaw cycles your lab has performed? What is your live birth rate? And do you have an age cutoff? Okay, so I do have stats. The most up-to-date and proficient ones would be the ones that I had in the slide, not too far behind. But we are definitely in the well over hundreds at this point, thaw cycles in general. And in terms of our live birth rate, the live birth rates in all of our age categories are consistent with our live birth rates of our fresh egg IVF cycles. So again, if we go back to one of my slides, I hope that's still available. Let's see if I can do that. Give me one quick moment. Okay, this is a pretty good, nice slide per age category, and year to year there are variations, but this is a good overall assessment of how we do in a year. of what our freeze-thaw rates are and what our overall success rates are per age category. And then, do we have an age cutoff? We do not. Of course, the woman needs to still have an egg supply, and we look for that in the ovarian reserve testing, the AMH value, the ultrasound, antral follicle count, but we definitely don't have a specific age cutoff. This is a back and forth conversation patient to doctor about, do you think it's appropriate that I really freeze my eggs at such and such age? But we don't have a specific age cutoff. Okay. All right. So I think that we are a couple more questions coming in. Okay. How many eggs per cycle is needed for a successful freeze cycle? Great question. Love this question. Of course, this is definitely something that will be a little bit age dependent, but I always try to give a number because people like to fixate on numbers. And I think that the average woman in the 30 to 40s, usually if they're sort of on the average fertility path, can make about 10 mature eggs in a cycle. So I always have that as kind of my minimum goal with any patient. As patients get older, sometimes they won't achieve that. And some patients' dreams or goals are to make a whole bunch of babies from these eggs. So that is probably somebody that I would say more than 10. So you may hear people quoting between 10 and 20 eggs would be a nice batch, because not all your eggs are going to turn into embryos, but somewhere between 10 to 30 from an extreme standpoint would be a wonderful amount to salvage. Now, if you are a person, which most women are not, that can make 30 eggs, that is not the expectation. The expectation is you can make as many as your body can make through that cycle, and with that knowledge, decide how many more cycles that we need to do. But to answer the question really simply, I really would like to get at least 10 mature eggs out of a patient as she's freezing her eggs. Thank you for that question. Okay, I think we're going to wrap it up about now. Again, I am available at any point. You can always call into our office, schedule a consultation, and whether you do or you don't, and you choose to do this or not, I hope that this was educational, at least helped you know that knowledge is power, and before you make any decision in your life, the more you know about it, usually the more relaxed you are as you commit. So good luck to you all, and it's been my pleasure, and thank you for listening. Have a good day.